2, 1. We are live now.
Yeah. Yes, sir. You can go ahead, sir.
Yeah. Good evening, everyone. It's a pleasure and privilege to talk to you about the 10 commandments for an ideal total knee arthroplasty. These commandments are formulated by me, not by any biblical figure, but I just coined them commandments because those are the important to be followed. And these commandments are not in any textbook, but I formulated them over the years because we have a very big teaching program with almost 15 fellowships every year. So all these fellows go through this process of learning. So I wanted to have a uniform platform of the standardization of the knee replacement. That is why the 10 commandments have originated. Yeah, next slide. Rajiv?
Yes, sir.
A commandment is a rule that has to be adhered to strictly. So that is a very important point. First of all, you should know what is commandment. I'm not saying 10 rules. It's a 10 commandments. That means non-negotiable. They have to be followed all the time.
Dr. Mohammed Naqvi, can you please mute yourself? Can everyone please mute themselves?
चलो खत्म करो जल्दी से इसको
Dr. Mohammed,
डबल
please
हेड
mute
क्या होती
yourself.
है ट्यूमर सप्रेशन में अंडर को
Yeah, I muted them.
Yeah, okay. I think boss also got muted. Okay.
Yeah, okay. So
Yes,
a
sir.
rule that has to be adhered to strictly and mandatory at all costs. That is a very, very important thing. And next slide, please. Yeah. And these are the endpoints to be achieved before we embark on definitive fixation of implants. So that's what I do every time. So whether my registrar is operating, whether my associate consultant is operating, but they have to show that these 10 commandments are fulfilled. That is how we maintain the standards. So whether you do 100 knees a month or 500 knees a month, it doesn't matter. All these 10 commandments have to be fulfilled. So now let us see what are these 10 commandments. First commandment is neutral alignment in coronal plane in full extension. That means there should neither be a residual varus nor a residual valgus. Mild varus is okay, but nowadays with kinematic alignment and functional alignment, slightly alignments are changing. But usually for all practical purposes, neutral alignment is coronal plane in full extension. Yeah, next slide. You got a video of that, Rajiv?
Yeah. Sir, no, sir.
Yeah, okay. So this is the one where the 5 degrees valgus slightly acceptable, but for all practical purposes, keep the alignment absolutely straight on. Okay, next slide. That is commandment 1. There is a video. If you see, by putting this one, the knee is straight. Then commandment 2. Rajiv? Yeah. Alignment in sagittal plane in full extension. So we have spoken about the coronal plane before, now in the sagittal planes. In other words, from the lateral side. So the knee should be absolutely straight on. Neither it should be in recurvatum, nor it should be in residual flexion deformity. You can see in this picture, the top picture is a neutral, that is acceptable. Recurvatum is definitely no, and fixed flexion deformity is also definitely no. Okay, because recurvatum is much more dangerous than this one. So that is commandment number 2 in the operative picture. Absolutely should be straight on. Yeah, next slide. Now commandment number 3, stability in full extension in both the planes. That means when you give a varus and valgus stress test with the knee in full extension, the knee should be rock solid. It should not have any movement or at the moment jog of the movement. Yeah, you can see the video here. Yeah, no video please. Yeah, okay, that is the sagittal plane, and I think there is a coronal plane, and now you can see that. Yeah. Now you can see varus valgus stress. It is rock solid. So that is commandment 3.
30 degree flexion.
Okay,
Retractor.
and yeah, now
30 degree flexion. Varus valgus.
yeah, even 30 degrees varus valgus also should be quite stable. Now let us move to commandment 4. Next slide.
90 degree flexion.
Yeah, that is what no medial or lateral joint opening. If the lateral joint opening means medial side structures are tight, medial joint opening means lateral joint structures are tight. So next slide. Yeah. So Commandment 4. This is what we call midflexion stability. So stability at 30 degrees, 60 degrees, and 90 degrees flexion by simultaneously putting the knee into varus valgus test and anteroposterior draw test and rotational stability. All these three things should be seen. You can see in the video. I'll show you, and you can show the video here, Rajiv. The bottom side of the video. Yeah, that is the video.
Sir, it's this thing.
Yeah, you just click on the center. Click on the center of the video. It should work. Or
No,
maybe
so
down
there's a
at the
picture,
bottom.
sir.
It's not a picture. It's a video for sure.
It's a video, 100%.
100% video.
Rajiv, or otherwise, go to the. How to test that midflexion instability is important part of the video. Rajiv, if we can't get that one, we will
Yes, sir.
finish this and get that.
We'll share
video.
yes, sir. We'll share the videos.
Okay. Then basically in midflexion instability, how do you test? A lot of people do not know. I will teach you. You take the heel of the leg into the palm or cup of your hand with one hand. On the top of the picture, you can see. Don't put your left hand. Your left hand should be free. And with the palm of the right hand, you keep moving the knee from 0 to 30, 30 to 60, 60 to 90. At the same time, rotating the leg and giving a varus valgus stress. All of things can be done simply the heel being in the cup of your hand. So I think I'm going to show the video in the next slide. Yeah. Next slide, please. Yeah. Next slide, please. Next slide, please.
Sir, fifth command.
Okay. Commandment 5. Femorotibial tracking. Meeting. Femorotibial tracking. Whether both the femoral condyles are tracking. Where both femoral condyles are tracking uniformly on tibia during the movement of knee in the sagittal plane. Okay, that is very important. Just 1 minute.
Rajiv, just make sure that Ratnakar, maybe you can locate that video meanwhile.
Sir,
Sure,
it's
that
not.
video is there.
Yeah, it's a photo. I'm not able to play it at all.
Maybe the link is not working. Just keep the video ready.
Yeah.
Once the talk is over, we can show it.
Okay.
Yes,
Then
sir. Sure.
Commandment 5. Can you hear me? Yeah.
Yes, sir.
This is
Yes,
Yes.
tracking. That means both the femoral condyles tracking uniformly on the tibia during the movement of knee in the sagittal plane. Next slide. Yeah, there is a video. I think this is a video.
No, sir. This is just a photo showing femoral and tibial
This is a
tracking.
photo. You can see the
No,
femur.
Rajiv, they all are videos for sure. I know because I made this presentation. I don't know if the link is working or not, but try.
Okay.
So the links are not working. Okay.
A and B are equal when you go to the femorotibial tracking. Next slide. Next slide. See, both spaces should be equal, and that is equal medial and lateral joint tightness. This is one of the most important commandments because that means that the ligament balancing is quite spot on. The next slide. Now you can see that if A is more than B, that means lateral tightness in flexion and extension, which is not right. Next slide. The same way, the other slide is medial tightness is more than flexion and lateral tightness. So both sides, the tightness should be good. Now, commandment 6 and 7 put together, we'll call that as a POLO test. That means pull off and lift off test. These both should be checked with the knee at 90 degrees flexion with patella inverted. So go to the next slide. And you can see that the top one is pull off positive. That means 90 degrees. You put your hand on the popliteal fossa and pull the tibia forwards. If the tibia is subluxing into the wound, that means flexion gap is loose. That means pull off is positive. So that is what it is. Here also, I think there is a video again. We will see. And the next slide. Now coming to the lift off. Lift off means when you got the posterior structures tight, then what happens is when you flex the knee to 90 degrees, the anterior part of the tibial base plate lifts. That is also called a nutcracker or booking effect. You can see in the right slide, the whole tibial base plate is lifting. So that is not right. So these two things are very important. So pull-off should be negative and lift-off should be negative. Yeah, next slide. So now Commandment 8. Now this is called optimum femoral rollback. So if you press the knee to 90 degrees, you can see in the first picture on the left side, the arrow marks are both showing pointing together. That means the midpoint of the posterior condyle of the femoral implant should touch the medial, it should correspond to the midpoint of the tibial polyethylene. And in the right side picture, you can see that the femur has moved way backwards on the tibia. That is called excessive femoral rollback. This is a very less understood by the youngsters, but this is a very important point. So if you can, when you flex it, if you can see middle 1/3 of the polyethylene in the wound, that means your femur has gone way back. That's not right. So when you fix it, hardly you see anterior 1/3, but never middle 1/3 of the plastic. So in fact, the right side is again a video, and I don't know why this is not showing. Now another thing is, wait a minute.
What we'll do is once the talk is done, we'll try to get all the videos in one and show them again.
All the videos
No,
are there. In
click on the play icon on the top. Just see if it plays.
No, sir. Play icon is putting it in presentation mode. That's all. Play.
Okay. It was
Yeah,
playing, we checked earlier.
Yeah.
Can you just press that play once? See,
Go on to the top and replay.
play on the top.
Up there. On the
Left
Rajiv
top.
on the top. On the left.
side. Left side.
Rajiv.
Yes, sir. 1 second.
Yeah.
The top.
There is
Just
only
above the
space
C.
line.
Clearly visible.
Above
there.
the C.
Play.
No, Rajiv.
It
On
was
the top,
playing
there is
like
a
that.
scale.
When you
Yeah.
flex the knee,
Okay, do one thing.
we can see-
Go back
Oh, sir.
to the
Yeah, I'll go
previous
to the
slides.
black. Yes, sir. I'll
Show-
just keep it in
Show all of
it's-
them again from the beginning if boss is okay with that.
Okay, show this one first.
Yes, sir.
when you flex the knee, if you can see the middle 1/3 and posterior 1/3 of the tibial implant trial, that means this is too much anterior. That means the rollback is too much anterior, and that will give enormous stress on the posterior part of the tibia. So in other words, optimum rollback means when you flex the knee to 90 degrees, only anterior when you flex the knee,
Yes, sir.
Yeah. Show the midflexion instability.
Yes, sir. 1 second. Sorry.
zoom out chesa. Okay. Okay. Now, good. Like this, Varus. Yeah. 0, 30. Move it 30. Yeah. 60. Move it. Keep moving. And rotate it.
So as I told you,
Yeah.
the opposite hand is free. Only with this hand you do that. If the knee pops out, that means flexion instability is present. So that is the important point in doing the midflexion instability.
Yeah. Okay. Good. That's fine. Midflexion stability. Which one? Patellar cracking.
Okay.
Yes, sir. Sir, can I play the femorotibial tracking?
Yeah.
Yes.
No, it is not playing.
Yeah, there's a crossover there. I think this video is not playing.
Okay, this one.
Okay. So
Polo.
pull off.
Yeah, okay, that's fine. Okay, good. అనుకోదేశండి నా లిఫ్ట్ అప్ లేదు కదా జూమ్ చేయి ఇక్కడికి వెళ్ళి ఇక్కడ లిఫ్ట్
Put it on mute and then play. Okay.
Okay. 1 second.
Yeah. Put the next one. Show the lift off.
ఓకే నో జూమ్ అప్ రైట్ ఓకే రైట్ గుడ్
You can see that
coronal
it is lifted from the
roll back
tibia,
roll back
the whole implant.
that's fine
That is the lift.
roll back
Okay.
రోల్ బ్యాక్ అంటే ఇక్కడ పైనుంచి 1/3 చూపించాలి మనం 90 degrees దాకా వెళ్ళి ఓకే 1/3 కనపడుతుంది కదా
Yes.
దాని తర్వాత దానికి
Starting with the Commandment 8, sir.
Yeah. This Commandment 8, and I say if you put a scale or blade, only anterior 1/3 is showing, and it is not showing the middle 1/3. And if you put the blade on the anterior part of the tibia, it should also touch the anterior part of the femur. That is the rough rule. You can see that. Yeah, this is what we call ideal rollback. Yeah. You can see that there. The blade is touching both the anterior part of the tibia and the femur at the same time. Yeah, okay. Next. Yeah, that is Commandment 8. Yeah.
Okay, how many measurements? Yeah, put it artery forceps. Okay, artery forceps. అది టిబియల్ బేస్ ప్లేట్ దగ్గర పెట్టి టిబియల్ బేస్ ప్లేట్ దగ్గర పెట్టి అక్కడ క్లిప్ చేసి ఇటు పెట్టు లోపలికి పెట్టు అవుట్ సైడ్ పెట్టు నౌ మూవ్ ఇట్ టు ద లేటరల్ సైడ్ హోమర్స్ కొంచెం ఓపెన్ చేయి రైట్ మూవ్ ఇట్ టు ద అవుట్ లేటరల్ సైడ్ సేమ్ అంటే ద డిస్టెన్స్ షుడ్ బి ద సేమ్ దట్స్ ఇట్ ఓకే right, got it. Yeah. Okay, now but I can కనపట్లేదు లిఫ్ట్ ఆఫ్ దీంట్లో లేదుగా లిఫ్ట్
Okay, move to the next slide.
లేదుగా
Yes.
Commandment 9, this is an important commandment. When you do these spaces, the rectangular and equal extension and flexion gap should be there. In other words, when you put the spacer, it should move from flexion gap to extension gap unaided and unprompted. That means you should not struggle and you should not push it with your thumbs. So getting this flexion extension balancing is essential for the satisfactory outcome. This is one of the most important point in the 10 commandments. There is a video. Let us see the video. Next slide. Now, this is a matrix of the stability balance, which we will send it to you. You can do this, no problem. Okay, the next slide. There is this flexion extension gap. Yeah, this is all, they will read it up. No, I'm not going to tell that now. All right, that one. You can see the video. Play the video.
Yes, sir.
Something is wrong. This is again crossed. I think we are not loaded the proper videos.
That was playing earlier. One second, sir.
No, go to the top and play that one. Go to the top.
This,
Gray, no.
okay, one second. This one, sir.
No, go to the top, gray scale.
There says play on the top, Rajiv. Can you see that on the
Right,
top? Yeah.
Yeah.
No, sir, that is just going into the complete share screen.
Okay, sir, okay.
So this I'm
Full
trying.
video will
earlier
show
it-
you. Okay, go to the next one. There is a video. Play this video. And now we can see this. It's well spaced. Now there is a spacer. It is in the flexion gap. Now I'm putting it to the extension. I'm not touching the spacer at all. See that. Now I'll come move it to the flexion again. It is sliding into the flexion. If you achieve this one, your knee joint is going to last for minimum 20 years. Take my word. Now you can see that again. Play it again. Play it again. Very important point. See, the spacer is nicely snug in both medial and lateral side in flexion. Now in extension, I'm not touching the spacer at all. It is nicely sliding into extension space. Now the reverse, you see that. I am flexing it. Now it's nicely moving into flexion. That is the one which you have to achieve. That means both medial and lateral side are equally tight and both flexion gap and extension gap are equal. What else you want? That is the thing you want. Okay. Now there is Commandment 9. Now go to the next slide. Yeah. Now Commandment 10, patellar tracking without the thumb. Yeah, there is a video again, I think.
Next
No?
one. Next one, sir.
Yeah. Yeah, you can see that. Patellar tracking. Yeah. So that's it. So that is without thumb. You can see I'm not putting any thumb at all. So these are the 10 commandments. Go to the next slide. Yeah, there is another commandment, bonus commandment I call that. You should be watertight closure of the arthrotomy is your achievement goal. Because sometimes if you don't use the arthrotomy properly, a simple stitch abscess can go into the joint and become a full-fledged abscess. So that's why the watertight closure is very, very important. You can close it in flexion and by dual suturing technique. That means one interrupted, one continuous. Don't delegate this to the junior most. I will pay heavy price on that. So do the arthrotomy closure yourself until your assistant gains your confidence. So this is another commandment. So next slide. So in other words, in summary, never neglect any commandment. Each one has its own significance. They let you know where you have gone wrong, and it is the last chance to correct yourself before you do implantation with the cement. I'm not talking to you about how to correct the problems. That one is for another day. But these 10 commandments, you should, everybody, we will send the videos also. Everybody should learn this by heart so that every knee, whether it is the 1,000 knee or 10,000 knee, you should just quickly, within 5 minutes, you should run through all these 10 commandments. Then you will be satisfied that everything is in place. Suppose if one is wrong, then there is a way to correct it. That we will learn it as we go along. So next slide. Next slide. That's all? Yeah.
Yes,
So that's it. Thank you so much. So these are the 10 commandments. I will just repeat and tell you all over again. Number 1 is knee in full extension in coronal plane should be absolutely straight, neither varus nor valgus. Number 2, in sagittal, commandment number 2, it's sagittal plane, the knee should be again straight, no place to recurvatum, no place of residual flexural deformity. Commandment 3, it should be rock solid in extension with varus valgus strain. Commandment 4, midflexion instability. How do you test it? As I already showed you, the heel in the palm of your cup, 30, 60, 90 degrees, varus valgus test, same time rotational stress. The knee should not pop out into the joint. Commandment 5, femorotibial tracking. When you put the trial implants and flex the knee joint, the femur should track uniformly on both sides of the tibia, mediolaterally. It should not be lifting on one side. If it is lifting on medial side, that means lateral structures are tight. If it is lifting on the lateral side, medial structures are tight. So this is important point. Here you will be releasing the ligaments or medial release or lateral release as per the deformities. And in the following lectures, Kushal will show you the varus deformity release and valgus deformity release also will be taught to you. And commandment 6 and 7 put together called POLO test. For easy remembrance, POLO means PO means pull up, LO means lift off. That means both should be negative. Pull up means when you put the knee into 90 degrees with the trial implants in place and put your hand in the popliteal fossa and pull the tibia forwards. If the tibia is subluxing forwards under the femur, that means the pull-off test is positive. That means if the posterior structures are too loose or your flexion gap is too loose. The other one is lift-off. Lift-off means when you flex the knee to 90 degrees, if the tibial base plate is lifting from the tibial cut bone surface, that means the posterior structures are tight and you have to do something, whether posterior osteophytes or posterior structures you have to release. And the reason this is also known as nutcracker effect or booking effect. Now, commandment 8 is optimum femoral rollback. This is the least understood and least appreciated, but every guy should know this. When you flex with the trial implants, when you flex the implant, the midpoint of the femoral implant of the posterior condyle should be corresponding to the midpoint of the tibia, but this you can't appreciate. So the easy way to appreciate is when you flex it, if you put a blade or a scale touching the anterior part of the tibia, it should touch the anterior part of the femur also. And another thing is when you flex to 90 degrees, if you can see only anterior 1/3 of the tibial polyethylene as it's seen here, that is the right one. If you see middle 1/3 and sometimes posterior 1/3 of the tibia, that means it is an excessive rollback of the femur, which is not right. So that is commandment 8. Commandment 9 is rectangular and equal extension flexion gaps. Again, this is a beautifully demonstrated here by putting a spacer into your extension gap and move it from extension to flexion and from flexion to extension without you touching the implant or without you touching the spacer, sorry. So the spacer should go from extension space to flexion space and from flexion to extension space smoothly, unaided and unprompted and unassisted. So that one I will show you in the next film. You can see in this video, you can see that one is beautifully, there's a flexion space, nicely tight on both sides, and now it is moved to extension space. Now the next thing, from the extension space, you flex the knee, you're not touching the spacer at all. Go back to that video, flex it. Yeah, okay. We let it go. flexion space, it tight on both sides equally, and going into extension space. Now from extension space to flexion space, it is going back nicely, unaided, unprompted. So that is Commandment 9. Commandment 10 is no thumb patellar tracking, very important again. And Commandment 11 is watertight closure of the quadriceps. So every arthroplasty surgeon, if you follow these 11 commandments and satisfy that all these commandments are met with, then your knee joint is going to be the winner. Thank you so much. Yeah, any doubts or anything else, we will be happy to answer them. Then we will go to the next class. Yeah, any questions? Yeah, Rajiv,
Yes, sir.
any questions? Stop this presentation.
Okay, sir.
Yeah,
No question so far, sir.
Yeah. So that means no delegates are there, or?
No, there are 80 delegates.
Sir, one question is cause for excessive femoral rollback,
Yeah,
sir.
cause for excessive rollback, again, tight structures on the posterior side and ill balancing of both flexion space and extension space can create, sometimes loose flexion space can create this excessive rollback. Yeah, that also can be controlled once you clear the posterior structures. Lot of the time, posterior structures, we don't pay too much.
Sir,
Yeah.
sir, we had lost you, sir. Can you just start once again from starting, sir?
The
No, we can hear.
excessive-
We could hear.
No,
We could hear.
Ratnakar, we heard it.
Okay.
Yeah.
I think you lost it.
You
yeah.
lost it. All the fellows should be in the video mode. Okay. So, Mustafa, everyone, do you have a bailout technique for what?
I think for excessive posterior rollback, you can slowly release the PCL fibers,
Yeah.
so that rollback will be reduced if it's too
Correct.
tight because of
Yeah.
that. If you're
Usually
doing a CR knee, basically.
excessive or extra tight PCL or sometimes posterior osteophyte. Basically, posterior structures too tight, they will pull the femur backwards. Yeah. Right. So, but as I said, for every fellow of sunshine or outside, you got to get all these 10 commandments right. Yeah. There is another question. Can somebody read it for me?
Sir, for midflexion stability, we should rotate the tibia or give varus or valgus force.
Both at the same time. I showed you in the video. You take the heel in the palm, keep rotating, keep flexing, varus and valgus stress, same time. You do it tomorrow in the operating theater, you know that how to do it. Very easy.
Yeah, you can do like rotate first and then do the varus valgus as well.
Yeah, simultaneously, while rotating,
Yeah.
you can just give a bit of push onto the lateral side, it becomes valgus. Push onto the right medial side, it becomes varus block. Yeah. Right. If everybody is happy with that, I think Rajiv, you
Yes,
got
sir.
to curate this talk as
Yes, sir.
every video should work.
Yeah,
Because there is a lot of editing to be done. Praharsha got a very good model. I think you have not taken that one. There is okay.
This is the same one, sir, actually.
Same one.
Same one, but I
So
think
actually,
some
videos
problem
were
with video.
playing, sir. Yeah, it
Yeah,
was
it's okay.
playing earlier, sir.
But again, send it to the fellows. It's a very
Yes,
important.
yes, we'll share all the videos, sir. Every
Okay, right, good. Right. So if that is the case, next talk.
Sir, before that, this
Ishq.
ISHK 23
Oh.
announcement by you, sir.
Yeah, yeah.
Rajat, can
Right.
you just
Yes.
share that one?
Right.
Yeah.
How many fellows are there? 80. Okay. Hi, friends. Let me invite you for ISHK 2023, 14th to 16th April in Hyderabad. And I'm going to send you all this flyer, 20 reasons not to miss. 100 beautiful academy session, combined American Academy of Hip and Knee Surgeon session, and combined EKSS, European Knee Society. So good faculty is coming, and USA, UK, France, Australia, and Canada. There is another thing called Young Surgeons Forum, and then robotics are bone stations. There is a ISHK quiz is there, and fun prizes are there, and nuggets from senior members. Another important thing is 24/7 open chat box answered by faculty in the conference app itself. So we can ask any question anytime in the chat box. Our faculty will be able to answer you. That is one of the best things which has not been done in any conference. And we got a lovely Ramoji Film City where a lot of things can be done leisurely. You can get your spouses and family. And RRR fame Rajamouli is coming and PV Sindhu is coming and they will chat with you. So a lot of fun is there. And first time we are holding a theme dinner for all the delegates. There is no faculty dinner. Faculty and delegates, all of you will be sitting together and we are giving complimentary dresses to the delegates as well, which is a very nice Nizam and South Indian themed dinner. It's a sit-down dinner. So it will be wonderful, both work and play. You will get a very unique experience. So I request all the fellows in this virtual fellowship to register yourself and come to the conference. We will give you a special concessional rate also. For that, you just get in touch with Ashok Shyam or Neeraj. We will give you a special resident package, some what we got special package. So I request all the 90 members who are in this fellowship, please join us in Hyderabad and we will give you certificates there on the stage with a nice photograph as well. So please be there in April in 2023, Hyderabad. Not only you, get your friends also. It is going to be a good big gala show. If you got any doubts, get in touch with Ratnakar. Thank you. Okay, is that enough?
Yes, sir.
Yeah, good. Yeah, next, what is going to,
Yeah.
Kushal is going to talk about Varus knee?
Yes,
That's
sir.
right, yeah.
Yeah, wonderful. Very important, all the guys. So listen to them and principles and practice of Varus knee. This is a bread and butter for every arthroplasty knee surgeon. So Kushal is going to take you through these steps. Off you to Kushal.
Very good evening, all of you. I'm Dr. Kushal. I work at Sunshine Bone and Joint Institute, and I'm excited to take you through this whole lecture on TKR in varus deformity. Now, the way we are going to do this is the principles will be outlined through the presentation, and at the same time, parallelly, I'll just demonstrate a case so that that same principle is visualized in a kind of a photo and video format as well. And then at the end, we'll show one more video just going through on a different patient, going through the entire process. So let's start immediately. I request my fellow colleagues to just answer any one-word answers on the chat box directly. But if there's any discussion points, then please interrupt me in the middle so that we can explain it in detail. Is my screen visible?
Yes, sir.
Yes, yes, Dr. Kushal.
Okay. So this is what it is, TK and severe varus deformity. Right, this is the outline. We'll go over the definition, then go to why it happens, etiology, and the classification, the pre-op planning, surgical principles with a demo case, right? So first of all, what is varus deformity? For that, we need to know what is normal alignment. So normal alignment is nothing but a limb where the center of the femoral head, the center of the ankle. When you draw a line from connecting these 2 points and it goes through the center of the knee, then that kind of a alignment is called a normal alignment. The same line here and the same line here, just have a look, center of the femoral head to center of the ankle, the knee lies outside or lateral to the line. That is called a varus alignment. And if it lies inside or if the line goes inside, then it's called a valgus alignment. Why is it not moving? Yeah, okay. Now in that, the definition of severe valgus, there is a kind of a variability in this. Okay, different studies have given different values to this. There's no clear-cut
Kushal, we can't hear you. I think we lost you in between. I think he's having some internet issue. Yeah, he got logged out. Just logging back in. Any other points you want to add, Ratnakar, till he gets back in? Ratnakar, Kishore. So basically, the 90% of cases you guys see in your practice will be varus knees. Okay, of course, he's going to be talking about the basics as well as how you tackle a more severe varus. But yeah, your 90% of your arthroplasty practice will be covered in this talk more than the other ones. So yeah, we pay good attention to what he's going to tell you.
So meanwhile, there is one question. Can we correct the varus or valgus cut during the surgery?
You mean in the tibia?
Yeah, tibia.
You can, as I think Kishore also replied to that. You have to shave off a little bit of the tibia, but then you can't keep on trying to chase it. Let's say you put in a varus cut, then you shave off this side to make it neutral, but then you end up putting this way. Then you keep shaving. You're going to keep on taking off too much bone. To be very careful, slightly shave off.
Freehand or without zig?
Both we can do.
You can do both ways. Yeah.
Sir, how to put the zig again? Because the pins we put, they are put during the primary measurement.
So what you got to do is put your jig. Okay, take a saw blade, just put it on the cut surface so that you're at the right level. And then you adjust your angle to make sure that it's a neutral cut. So you must be in a varus or a valgus. So put your saw blade just to get the right level. And then you adjust your angle so that you get a neutral cut. You can't depend on the pin holes because most of the time you won't find them again.
Okay, sir.
The other thing you can do is you can hitch it on one pin, and then based on whether you are valgus or varus, you can move the rod to the opposite side.
That's if the pin is still inside.
Yeah, so you can hitch it on one pin and do it.
Sorry, I don't know when I kept talking. I don't know what.
So we were on the definition of severe varus. We lost you there.
Oh boy, I spoke for 4 more slides. Okay, is this the new slide?
Yeah, the previous slide you can start from. Previous slide.
Yeah, that was just the definition of severe varus. So 15 degrees or more, let's consider that as severe varus.
Go to presentation mode.
Yeah. Okay. So, right, when it comes to etiology, the varus deformity may happen because of extra-articular, that is in the femorotibia, or intra-articular reasons. Extra-articular, you have dysplasias, rickets, fracture malunions, and intra-articular, of course, the osteoarthritis. Now, for today's purpose, we are focusing on the intra-articular part. Extra-articular deformities and all that we will cover in a subsequent class. In terms of classification, we have a newer classification given by Thinepoint and Parvizi in 2016. It classifies into intra-articular, metaphyseal, and diaphyseal. Again, what Sir was talking about, the bread and butter, it's the fixed varus without lateral laxity and the fixed varus with lateral laxity. These are the ones we are focusing on today, and these are the ones you're going to most commonly encounter. In terms of incidence, males and females, no difference, it's the same. Most of these have some varus alignment in childhood, which gradually progresses after 50. And the source of deformity is in the proximal tibia. Lateral subluxation of tibia is common. I'll show that. In terms of pre-op planning, it's the same, no big difference, but just insist on AP full-length hip to ankle radiographs so that the measurement of the varus angle is possible. So quickly, I'll ask a question. Is there a role of mechanical axis of the lower limb in measuring varus valgus deformity? So if any of the fellows are do know the answer, want to guess the answer, just type in the chat box. Ratnakar, I can't see the chat box. So if you see any answers, just let me know.
Yeah, I'll inform.
Yeah, anybody?
No answers so far.
No answer. So yeah, so I'll show you how it's measured. Okay, there's something chat. Yeah, so somebody says no and somebody says yes. Someone else says no. So Ajay, the answer is actually no. You don't need this long axis. What you basically need is the mechanical axis of the femur and tibia. I'll show it to you. Yeah. So how do you measure the varus? Mechanical axis of the femur. So it's this dotted line that's drawn here from the center of the femoral head to the center of the knee and just extend it downward further. And then this is the mechanical axis of the tibia, which is the same as the anatomical axis along the shaft from the ankle to the knee center. So the angle here A that is formed is the varus deformity. So basically this long axis of the lower limb, mechanical axis of the lower limb, has nothing to do with the measurement of the varus angle. And in terms of lateral subluxation, what do you do when you have this subluxation? How do you measure the deformity? Because the
Hello?
center of the
Sir,
Ratnagar, mute. Yeah. So these 2 points are different. So you can just go in the center of these 2 points and complete your measurement. And again, the next question is it possible to measure varus deformity without full length radiographs? Anybody to take that answer? Like this kind of a radiograph, can you measure the angle? Because most of us work in centers where we don't routinely get long leg radiographs. But is it possible? Yes, no? Yes. So it is possible. Ruchit, you want to tell how? Or should I go on? Yeah, it's a little, it'll be understood better if I explain it. So here's how to do it. Again, you see this lateral subluxation here. Now, this is a 62-year-old female. In fact, this is our demo case. I'll show you a video of this as we go along. 62-year-old female with type IA varus. We're going to plan a debut PFC on that. But before going into the implant and all that, you've seen this X-ray. You don't have a long leg film, but you want to know the how much is the varus deformity. So for that, you will that's your highest part of your trochlea. So you need to just extend it along the anatomical axis of the femur. So that's basically the shaft of the femur. Just draw it upwards. Then the same point tibia along the anatomical. So now anatomical axis of the tibia is the same as the mechanical axis. So you don't need to worry about the tibia. And then the center, as I told you, the midpoint of these two. So just draw this orange line, which is parallel to the femur anatomical axis here. And this one, which is parallel to the tibial anatomical axis, so that they both join together. And once you get this, you have the angle between the anatomical axis of the femur and the anatomical axis of the tibia. All you need to do is you need to give a 6 to 7 degree, because that's usually 5 to 7 is the range between your anatomical and mechanical axis of the femur. So you just need to put that line down and then measure the complete angle. So this whole angle, this entire angle will be your varus deformity. Anyway, this is more theoretical. More before your case, you know that there is a gross varus and you need to make it neutral. So don't really get into the technicality of the measurements. 15 degree, 20 degree, 30 degree, not really required, but just theoretically, you should know how to measure it, right? Now, once you see the radiograph, you have to do a clinical assessment also, and the best time to do it is just after anesthesia. So in your clinical assessment, the valgus stress test is important, because if it's a correctable deformity, the varus gets completely corrected to neutral. It implies that the varus has come because of only bone and cartilage erosion. So what you're going to think of is there's not much of soft tissue release that's required for that case. And when you come to the fixed, that is, you've given a valgus stress, either it is completely fixed there or it's only partially corrected and it's not come back to complete neutral, then that means that the medial structures are contracted, which means that adequate soft tissue release is definitely required in that kind of a case. So that's more of a challenge. So you need to kind of be ready with more releases. Mentally, you have to be ready. And of course, the varus stress is also important. That one is for the lateral laxity. So in this case, our case, this is what it looks like in full extension. It's a left knee. So you can see the varus deformity going inward. And then here's the video. Yeah, that's the video. I'm going to perform a valgus stress, and you see the limb is not coming to neutral position. So this means that it's only a partially correctable varus deformity. And in my mind, soft tissue release is definitely required for this kind of a knee. Now, when you go through the surgical principles, let's go step by step from 1 to 7. We'll go over exposure, then balancing in extension, balancing in flexion, then the trialing, and any additional medial releases, final balancing, and then we'll go on to how the tibial bone defect is addressed at the end, and of course, managing the lateral laxity. So let's go for exposure. Now, these two are absolutely the same. Midline incision, medial parapatellar orthotomy. There is absolutely nothing different in terms of reaching the joint. So no difference in exposure. Now, balancing the extension gap. The most important part is that for severe varus, balance the knee in extension before going to flexion. So basically in varus knee, your medial part is tight, your lateral is lax. So try your best to get a rectangular extension gap first before going to your flexion gap. So in the first couple of steps, subperiosteal dissection of capsule and deep MCL. This is the same. Now for our routine knees also we do this. But here the pearl is that you need to go all the way back to the semimembranosus bursa. And of course, the same time you can release your medial osteophytes. So in our routine knee, this is where we would stop with our exposure. That is the superficial, the capsule and the deep MCL. And in this severe varus, you have to go all the way behind the mid-coronal plane to the semimembranosus bursa. So let's see how that's done. Oops, yeah, that's good. So here it's the left knee. So I'm going medial. We have made the incision, completed our arthrotomy. So now we are on the proximal tibia. This is the superficial MCL, the capsule and the deep MCL at the mid-coronal plane. For our routine knees, we would stop here. We don't need anything further to be done. But because this is a gross varus and we know that there are releases needed, we just put in a Homans there at the rim and then go all the way along the border of the tibia. And you can see the stretched fibers over there. There you can see those. So just under the Homans at the rim, go all the way back and reach behind the mid-coronal plane all the way to the semimembranosus bursa. Now, once you do this, you can just see when I do a slight valgus test, stress test again, it's correcting better. There you go. There you saw that jog. That's better than what happened pre-op. Right. Any quick fellows to take this? Can we take a regular distal femur cut for varus knees, severe varus? I'll look into the chat box. Any answers? It's not that difficult, yeah.
Yes. Many
Okay.
people have answered yes.
Yeah, so that's very good. So a regular distal femur cut, that means what I mean is, do you need any difference in the distal femur cut when it comes to varus? So the answer is no, it's absolutely the same. As we said, the second step is balancing the extension gap. So in extension, the first thing you do is the distal femur cut. It's standard. And the reason that it's standard and not changing is that the source of the deformity is in the tibia. So you go ahead with your routine 5 to 7 degree valgus angle cut. The only time when you will have to do something more is if it's associated with a severe FFD. So if it's more than 15 degree FFD, some people prefer to complete the additional distal femur cut before itself. So you can take a +2 mm and then move on.
Yeah, can I interject here, Kushal?
Yeah.
Yeah, such a very important point that he mentioned here. The fact that in a varus knee, your deformity is in the tibia. This is going to be as opposed to valgus knee, which will be coming in the further talks later, where the deformity is also in the femur. So you're going to have to change your distal femoral cut in the valgus cases. So you don't take a regular valgus correction angle that you do then, like in varus. So just keep it in mind for the further talk in valgus.
Yeah, correct. Yeah. Now, true or false? Measurement of proximal tibial cut is never based medially. True or false?
True.
I can't see the chat. Is it true? Ratnakar, can you help out?
Yeah, most people have put true, I think.
True, yeah. So that's perfect. Correct answer. So now you're balancing the extension gap. You're on the proximal. You finish your distal femur. Now you're going to the proximal tibia. It's the routine proximal tibia cut, which is laterally based. So lateral basing is important because you're going to have some gross varus deformities where the defect is massive. Almost 15 mm defect can also come in. So you can't place your stylus on the medial side at all. You need to place it on the lateral side. Okay. Just try to shut this. Sorry, 1 second. Okay. Right, so that's the next point. Do not aim to reach the medial defect. Do your regular routine lateral based proximal tibia cut and then go and check your extension gap. If not rectangular, shift tibial base plate laterally resect more bone after sizing the tibia. So this is called the shift and resect technique. So you see here how the tibial base plate has been placed. What you're going to do here is you're just going to shift this more laterally over here and then finish off your medial osteophytectomy, or remove that medial extra bone after sizing the tibia. Now that should give you a balanced extension gap, but in simple cases. If this happens, in most cases, the balancing and extension is complete. But now we are talking about bigger deformities, gross varus. So let's see what happens here. You can see in the photo here, it's a left knee. So this is the stylus goes laterally. So lateral base sizing. And then once you cut the routine cut, yeah, this is a defect you're left out with. So the point here being, don't put the stylus on the medial side at all. Now, this is the extension space with a 8 mm. Once we cut the distal femur and the proximal tibia, you've tried to put in your spacer. You can see that it has struggled to go in medially, but at least a little bit is going in, and laterally here, there's still a big gap. So you're not really able to push in that spacer. So that's where we are right now. We have done then we've sized the tibia. 2.5 is the size that we got. We sized it and we marked out the excess bone medially, and we've done a medial osteophytectomy. This is the next step we did. Yeah, you can see that you just release any soft tissues attached to that excess medial bone on the beyond the plate, and then go ahead and remove it.
Yeah, that's a very important point that Kushal mentioned just now. Before removing that osteophyte, detach all the adherent fibers. Only after detaching those should you actually go for the removal of the osteophytes. It's very important to do that.
Yeah. And then you've gone in and put your spacer in there. Now it's better. You've added this 2 mm shim. So the 8 mm spacer has become a 10 mm spacer, and it's gone in. So right now we think, or we're comfortable with our extension gap. Now, theoretically and practically, the spacer is not always the most accurate way to assess a gap. It's finally at the trials. So I'll explain this point later as we come back to it. But for practical purpose, for the right now, the extension gap is balanced. So then we go on to our flexion gap, right? Now it is best to use, true or false, to use the posterior condylar axis to determine external rotation of the femur in varus knees or severe varus knees. Any answers here?
Waiting for them.
Yeah.
True. Dr. Abhijit Sen has said true. True. Ajay Singh has said true.
All right. So actually the answer is false. Then this is the reasoning. Okay. Okay. Now, of course, balancing the flexion gap, it is performed after the knee is balanced in extension. It is determined primarily by femoral component rotation. So your extension gap after your distal cut and proximal cut, you did some releases and osteophytectomy and all that. Here, it's the rotation which is going to make your flexion gap rectangular. So the standard 3-degree external rotation may not be sufficient as it's tight. Okay. And what happens is the medial condyle may be hyperplastic. Not all cases, but majority of your gross varus knees, your medial condyle is hyperplastic. Thus, what happens is the external rotation has to be increased. I'll show it to you in a, yeah. So just now this is actually, left knee. So this is your medial condyle. Now, if you place your posterior lips of your external rotation block, the sizer block that you use, if you put them in one over here and one over here, because of this hyperplastic medial condyle, what happens is that this implant tends to go into internal rotation, because otherwise for a normal case, this black dot would have been higher up. So the danger with using the posterior condylar axis for gross varus knees is that the hyperplastic medial condyle is going to cause your implant to go into internal rotation. So just if that's not understood, I can show it to you here. Yeah. So in this case, it's actually not very hyperplastic. So imagine this is the left knee. So you're putting in your rotation jig, external sizer in here along the posterior condylar axis, and then you got these two pinholes. So now you need to just confirm whether these two pinholes are parallel to the transepicondylar axis or parallel to the already cut tibial base. So one of the good or easy ways that you can do this is just put some kind of a spacer in between, and then lift the leg. So you're going to make the ligaments taut, the femur up and the tibia down in 90 degree, and make sure that this line that I've drawn here, that is parallel to your tibial cut, right? So if that's the case, that means you have not gone into internal rotation. You can safely proceed. Yeah. So again, we have to match. So that's the point here.
Kushal, can I just answer one question that was asked?
Yeah.
I think somebody asked, how do you change the position of the pin?
Correct. Yeah.
So you want to just take that? You can just mention.
Yeah, that's a good question. So there is some implants, some companies come with luxury to increase the external rotation from 3 to 4.5 to 6 degrees. Not all, but some of them have it. So the trick is this last point. The medial pinhole is raised such that the cut is parallel to the tibial cut. So in these two, suppose this has gone into internal rotation, the yellow line. What you're going to do is you're just going to raise the medial pinhole such that this black line then becomes perpendicular to your tibial cut. That's the way that you're going to do it. Now, whether that 3 becomes 4 or 5 or 6 or 7, it doesn't matter because it's now parallel to the tibia and the flexion space has become rectangular. So now the whole idea is we got a 10 mm spacer to go into your extension gap. So we need to match it to your flexion gap. So you just ensure that you put in that 10 mm spacer there. Again, traction on the femur, traction on the tibia, and you mark out where you want your cut to come. And then as you go into your AP cuts, you just match the line that you've drawn here. Just ensure that it's the same level that you're cutting your posterior cut. Right. So we did that, and then we came on to the outcomes of the trial. So what happens? We put in a 2.5 femur, a 2.5 tibia, and first we go for the minimum poly, that is the 8 mm poly. So now let's see what happens in extension. Now in extension, you can see that the limb has come out straight, but as you start, as Reddy sir talked about the varus valgus commandment, you see what happens here. There is a opening laterally. So it's a pretty big opening, 2 to 3 mm opening, which is happening on the lateral side. So you're not happy with that. So although your spacer block showed you that, it was all very well balanced, it's actually not. The trials showing that 8 is loose, but 8 is tight in, it's going in medially, but a 10 was tried after this. A 10 was not going in on the medial side. So then again, you look at the same thing in flexion. So is it only tight in extension or is it tight in flexion as well? So you can see that when you do your pull-out test, the pull-out test is going to show that there is a significant translation. You can see because of the medial tightness, the poly is not moving right now, but you can see the tibia under the whole base plate moving, and you can see the gap also over there. So our inference from this trialing is that the 8 mm poly is not sufficient for our lateral side, and there's a laxity both in extension and in flexion. Okay, so what are our problems after this trialing? The medial tightness is both in flexion and extension. Medial side accommodating only an 8 mm poly, and then there's a lateral laxity with a 8 mm poly. So then what do we do? This is commonly seen in the varus knee, these problems at the time of trialing. So then we're left with doing some additional medial releases and then final balancing. So how do we achieve that? So everyone must know this table. I'm not going to go into the detailing of each of these points, but let's do it for this case here. This is full extension and this is flexion. So we saw that the medial compartment is too tight. Medial compartment is too tight. So then what's the first solution here? Release the superficial MCL, or in brackets, downsize tibial base plate and resect medial bone and recheck balancing. Our personal best technique to do is to start with downsizing the tibial base plate. So so before I come to that, I'll just quickly show you the functional anatomy on the medial side of the knee. Anteriorly, you have the superficial MCL and the PES. These are the most significant structures there. And posteriorly, the POL, the posterior capsule, and the semimembranosus. This is how it's going to run. Look at this diagram. This is your deep MCL right there, but your superficial MCL runs from the epicondyle all the way down, and it has two attachments. One, the POL over here at 2 centimeters away from the joint line, and then another 6 centimeters. So that's how low down it is. Okay. So our initial medial release, which we do over here, is not at all insulting the superficial MCL, because it's going on the side all the way down, right? You can see the attachment here. Superficial MCL, one attachment here and one attachment here. Yeah, and the POL also, right? In full extension being tight, in flexion becoming lax. Yes, and then where is the PES in relation to the MCL? So you can see that it is more superficial and a lower down structure. So you will see that these are the collateral, and then these are the three PES tendons: MET, gracilis, and sartorius, more superficial and lower down. The insertions are close to the tuberosity, about 1.5 centimeters away. So this functional anatomy on the medial side, let's recapitulate it. SMCL, superficial MCL, anteriorly, and the PES, which I showed you, and posteriorly the POL, the posterior capsule, and the semi-membrane. These are the structures that you need to know. Yeah, so another question, true or false? Medial release done anywhere, anterior or posterior to mid-coronal plane, affects both flexion and extension gaps equally. Anyone want to take that? Just pause for a second.
No is the answer. No,
Okay.
no, false.
Yeah, so very good. So this is the basic principle of your medial release. Now, anterior release, that is anything you do anterior to the mid-coronal plane, is going to affect your flexion gap more than your extension gap, and a posterior release affects your extension gap more than your flexion gap. So this point you will need at that time of when you're doing your trial reductions, and you see that there is a mismatch in flexion, right? In this case that I showed you, there was a tightness both in flexion and extension. But in those cases where you have a differential tightness, that means in extension it's normal, but in flexion it's too tight, or the other way around, this is the slide you'll have to remember, and do selective release either anterior to mid-coronal or posterior to mid-coronal plane. So this is our preferred, and you can just follow this because it's a good sequence of medial release. In the beginning, you finished your deep MCL and you reached the posterior medial corner of the knee, and then you completed the osteophyte removal. All this happened in the beginning itself. Again, POL and capsule. Then the next one, which mostly does the trick, and most knees get balanced while you come to the semi-membranosus. So that's our mostly the limit of where we do our releases for 90% of even gross varus knees. But those that don't balance even after this, we can go ahead and do a pie crusting of the MCL. PES release and a medial epicondyle osteotomy, they are there. I've seen it in textbooks, but I've never had to do it.
Kushal, we lost it.
Sorry, can you hear me now?
No, no, Dr. Adarsh, we are fine.
Yeah.
Sorry.
Okay. So now the outcome. So let's go back to our slide. Where at the time of trialing, we had medial tightness both in flexion and extension. We had medial side accommodating only an 8 mm poly. So for both these problems, the solution that we can do is downsize from a 2.5 tibia to a 2 tibia, and SLR means shift laterally and resect. And then this lateral laxity with an 8 mm poly. So we are hoping that after downsizing and shifting laterally and resecting medial bone, the medial opens up to a 10 mm poly, so that you can accommodate a 10 laterally as well. So this is the first principle in this table. That's what we use, because in full extension, we were tight medially. In flexion also, we were tight. So we went ahead and used the first principle, which is downsizing. And let's see what happens. So you can see the number of the tibia here. It's a size 2 now. The moment you put a size 2 and place it all the way to the corner of the lateral tibial rim, you see that so much bone now is there for you to remove. So once all this is visible, again, just remove the soft tissue on the attached to this bone, and yeah, go ahead and remove it off. So once you finish removing all of this, the medial will automatically open up, and we can accommodate a 10 poly. So now is the trialing with a 2.5 femur and a downsized tibia, the size 2 tibia, and we were able to put in a 10 poly. So this,
Can I just interject here? Sorry, Kushal.
yeah.
So the reason for this, some of you may be wondering why this actually happens. Like, how does removing that bone give you that looseness? Basically, you're reducing the tenting on the medial structures. So the medial structures have to travel over that bone and go up. Once you remove that bone, that becomes lax. That's how that helps, just for the uninitiated.
Yeah. And in flexion as well, no pull out. So we're happy with our balanced trialing with a 10 mm spacer. And that's your post-op X-ray. You can see on the post-op X-ray how much at the lateral edge this base plate has been placed. And you can actually see the reduced, that is the medial reduction osteotomy done after downsizing. So these are the tricks to go over that. And now the last 2 points, how do you address, because we spoke about tibial cut being at the level of the, I mean, not at the level of the defect, but above it, laterally based. So you're left with a tibial bone defect. It's pretty straightforward. In varus knees, the type of defect is an uncontained defect. So this is as against valgus knees. In valgus knees, because of the hypoplastic lateral condyle, distally and posteriorly, you have a small femocondyles hitting the tibia. So you have a contained defect on the lateral tibial plateau. But in varus knees, because we spoke about the hyperplastic medial condyle, this medial condyle will create an uncontained defect on the tibial medial plateau. So if it's less than 5 mm, cement is enough to stabilize the whole thing. If it's between 5 to 10 mm, cement with the screw. The only precaution with screws is that they should not go and hit the tibial base plate. They should be just a little below. And the purpose of screw is not like any other place in orthopedic surgery where it's used for plate fixations and getting things together. No, this screw or multiple screws, 1 or 2 screws, the purpose of this is a scaffolding. That's about it. It's just a support for that cement. So that's why the screws are put in. And then, of course, you have a bone graft. We have a nice video after this for the bone graft and how it's prepared and put in. For primary cases, we rarely use wedges or augments. It's more to do in revision cases.
That is RAND classification. Just trivia. RAND classification. Less than 5, 5 to 10, more than 10 mm. RAND classification.
And then the lateral laxity. So you will come across this and then you'll think to yourself, what should I do? Should I do something more? Should I do further releases? This is where you're stuck at the end. You feel that the lateral is loose and the medial is tight, and then you're tempted to go ahead and go on releasing medially and do something more to it. So this lateral laxity is acceptable if in resting position, resting extended position, you have put the knee straight, the lateral side does not open up. So we're not talking about a varus force. We're just saying in resting extended, that medial, if it's too tight, which causes a lateral gap between the poly and the femur, then yes, it's too lax. But if you just have, if it doesn't open up that much, and it's only the gentle varus force that's going to cause a 1 to 2 mm opening on the lateral side, that is acceptable, absolutely fine. And the method to manage this lateral laxity is, again, increase the medial release and use a thicker poly as we did in the above case. Advancing the LCL on the femur to tighten the lateral side, or a distal advancement of fibular head. I have never seen or done this, or not needed to do it, but it's there. Theoretically, it is there. Can do it. So in terms of messages, insist on full length AP X-rays to know the site of deformity. Pre-op valgus varus stress tests are very important. Balance the knee in extension before flexion. This dictum is not there in valgus knees. I will tell you why in the next valgus thing talk. Balance the knee in extension before flexion is done. Do not aim to reach medial defect during tibial cut. Address the medial defect at the end with multiple options available. Understand anatomy of the medial side, but for practical purposes, anterior releases affect the flexion gap more than extension, and posterior releases affect the extension more than the flexion gap. Of course, don't forget to address the lateral laxity. Yeah, whoever wants to read up, these are the references. And with that, the first part of this is done. So I'll just pause here. We can take a few questions if they are there. And then after this, I will take you through a full case, step by step, through a video. But just in terms of principles and how it is addressed and how to approach a varus. If there are any questions, we can take them now.
Yeah, Kushal, one question is, should we use tibial extender in all these 4 scenarios?
Which 4 scenarios? Sorry.
Dr. Abhijit saying,
Sir, if we fill the defect with cement, or if we use screw with cement, or if we add any augment, in all these 4 scenarios, should we use tibial extender? Is it mandatory?
No, it's not mandatory. Definitely not if it's a small defect, less than 5, no. If you're going to the level of bone grafts, yes. Anything more than 10, yes.
so it is generally said if your defect is more than 2/3 of your medial condyle, then we should go with an extension rod. So again, also depends on the quality of the bone you're dealing with.
Stop the
Yeah,
presentation and go to the, See, when you are in doubt, put a rod, but the rod should be short and stumpy. Unlike in the olden days, don't put long rods. We still put a very, very long rods. I think we should be discouraged about that. Short and stumpy rods, those are the best things. Yeah. The osteoporotic bone, if the poly is more than 12.5, the medial defect is taken by wedge of bone grafting. To offset the load, as simple as that, to offset or to bypass, not offset, to bypass the load forces in the joint, the rod is used. So it's a simple common sense. Whenever you feel that we should bypass the load from the joint because of the osteoporotic bone, because of the obesity, then you put a rod.
One more question. While placing the femur implant, significance of lateralization. So this was asked by Dr. Praveen.
Significance of lateralization of tibia or femur?
I think he means about the lateralization of tibia in shift and dissector technique. So how does it affect the femur implant? I think that was his question.
No, they won't be. Yeah. All we are doing is we're just going 1 or 2 mm more laterally. We're not, the main point here is to downsize. The lateral shifting is not like a major shift. You're anyway going to be on the rim. When you size the tibia, even normally you're going to keep it just on the rim. What we mean here is go as far lateral as possible and then get the medial bone off. So it has no significance in terms of femur implant. That's the question, right?
Yeah, I think that's. So Dr. Rajesh has got question. If medial side is tight and lateral side trial poly is going snugly, how will the downsizing of tibia help to insert the poly of higher thickness?
Yeah, that's what we explained. No? So once, if the medial is tight, the downsizing will give you excess bone on the medial side. So you remove that excess bone and you release the soft tissue attached to that medial bone. That creates space and that causes a release. So a higher poly can go in medially.
Not only that, the moment you downsize, you will do almost like a reduction osteotomy. When you take off the medial side reduction osteotomy, all the soft tissue structures attached to that part will be released.
Yeah.
I think in other words, it is a soft tissue release, but through the bone.
Yeah. I think I got the question. What he's asking is, if medial is tight and lateral side poly is going snug, then how will downsizing help to go to a higher poly? You don't have to go to higher poly. It's just that the medial was so tight, it was not allowing that poly which went in snugly on the lateral side to go in. So then you will settle for that poly which is going properly on the lateral side. You'll just create a space for the same size poly.
Correct. Don't increase poly at all.
But won't that lateral side be loose, sir, by downsizing the tibia, because it was only on the medial side where the tightness was there?
No, not really. Lateral side is snugly fit. Medial side, you are releasing the structures that will open up 2 millimeters gap on the medial side, not on the lateral side. So that will be snug.
Yeah.
So guys, varus deformity is as the bread and butter. 80% of the patients are varus deformity. You got to know how to release, because sometimes you get a horrendous deformities, but don't get intimidated. Any deformity can be nicely tackled, and 9 out of 10 times you don't need a bone graft, you don't need medial wedges. By simply doing these principles of undersizing the tibia, lateralizing the tibia, doing a reduction osteotomy, releasing the soft tissue on the medial side, post-coronal plane, all these things can address the gross varus deformity also nicely.
Is there any maximum limit of tibial cut in case of high FFD? So,
Tibial cut.
Yeah, in
Tibial
tibial,
cut is
if
standard, 10
FFD, it's not
millimeters.
tibial cut that you should go for. Yeah, you should increase your distal
Or at the
femur
most
cut,
you can
not
cut
tibial.
12, but not more than that. But FFD,
is it audible? Yeah, so Dr. Abhijit, if you got the answer, routine tibial cut, if anything from your regular 9, you can go up to 12, 13 mm, but not more than that. But the focus has to be on the femur side. So you're going to
distal femur.
Yeah, distal femur cut, posterior osteophyte removal, posterior capsule release. So focus on these and not the tibia. That's the message.
Okay, sir. Okay, sir. Thank you, sir.
What
What
size?
sizes femur match with the tibia, sir? Different system has got different mismatch.
Yeah.
Uh,
You just should know.
we will
And there's no
just
basic
give a-
question. Yeah,
Yeah,
sorry.
all questions are good
Yeah,
questions.
yeah, we feel free to ask any question. Okay, and don't think that any question is silly or anything like that.
So you just have to know what system you are using, and for that system, look at the matching.
Usually, most of the systems, 1 up and 1 down.
Yeah.
Some of the systems have got 2 up and 2 downs also, but most of the deputies, for example, 1 up and 1 down.
Yes.
Zimmer is 1 up and 1 down. I think 2 up and 2 down is
Smith and Nephew, sir. Smith and Nephew.
Nephew is 2 up and 2 down. Yeah.
And for Zimmer Next Gen as well as the Merrill, they have got in the femur side sizes from A, B, C, D, E, and they have got different tibial size. For A, we can use 1 tibia. For B, we can use 1 and 2 like this. They have a table for that. I think I'll try to share by next time this one.
Yeah. After keeping the tibial plate to the maximum lateral and there is no cortical bone on medial side poly is tight, lateral is snug, round the corner soft tissue release done, still medial is tight, trial poly taking bone on medial side, What should be the next step? So yeah, it is, you have to do releases. There is no other way. Yeah, so the table that we showed, you have to go to the next part of that table. So you have to begin with your superficial MCL and you have to go all the way back, semimembranosus, you can you can see the attachment of the semimembranosus onto the posterior medial aspect of the tibia. You can go and release that attachment. You can do pie crusting of the MCL. There are multiple techniques, whichever one you're comfortable with, you can keep practicing those, and this medial release can be done that way. One trick to do this medial release is, usually what we do is we dislocate the tibia and we keep the knee in hyperflexion. So that you get access to that posterior medial corner, you can take the tibia in figure of 4 position. In figure of 4 position, you can go right and see all the way to the back of the tibia medially. So that's, and then release under vision.
Yeah, technique is figure of 4. So basically, if you are operating the right knee, the foot should be almost touching the left leg or even going beyond the left leg. So lift the right knee and put it on the left shin of the leg of the left shin or left tibial shin, and let the knee fall outwards. That is a figure of 4. And then you will see nicely the posterior medial structures. Under vision, you can release them.
Yeah.
Gross osteophytes in extreme varus deformities, this is the best technique. So I'll repeat. Put the heel of the right leg, that is operating leg, onto the mid shin of the left tibia. And then let the right knee fall outwards. Don't even touch. Then, if you want, you can ask the assistant to push it further out. Then your beautifully posterior medial structures are visible.
Yeah. So the answer is, Dr. Praveen, releases. You have to do more releases. In fact, if you just go to some cadaver and just dissect the medial side, you will see how long that MCL is. We only take up to 2 millimeters below the tibial base plate. Actually, all the way down 6 centimeters. So you can do
Four fingers. Four fingers.
4 fingers. That's right.
You can put the 4 fingers, the tibial attachment.
So for those very severe cases, you can go all the way down there.
And again, the more posterior you release, the more distal you should release. Only just rim cannot be done to the posterior. If you are going to the beyond or behind the mid-coronal plane, you should go down also. So that's the important point. You just cannot release only top of the mid-coronal plane because the fibers are oblique and coming down. So if you want to release the posterior part of the mid-coronal fibers, you should release the bottom also.
So we'll go on to the video.
Another important thing is you should tell when you release this extensive MCL in the gross varus deformities, there will be a lot of bruising posteriorly on the medial side. And the patient will be very, very scared. So explain to them after the operation, we have to release a lot of tissue. There can be bruising, but don't worry, it's a part of the game.
Yeah. Dr. Abhijit, you can unmute and ask. You have some query about referencing.
Yes, sir. Sir, actually, I have a doubt. When we measure the distal femur using the normal available zig, suppose there are most of the system have 2 pins. One is written posterior and this is anterior. If we put both the pins, posterior and anterior pins, and we measured the distal femur, we got in between size. If I remove the posterior pins and put the 5-in-1 cutting zig in anterior pins, will it be leveled as a anterior referencing?
I didn't follow actually. I'm sorry.
Suppose, sir, while measuring the distal femur, the zig has got 2 pins. One is written anterior and another is posterior. While fixing the rotation.
So distal femur has nothing to do with referencing. And
sir,
and not at all to do with rotation.
No, sir. After getting the extension gap, while we further progress with the distal femur condylar cuts, while we take the measurement.
No, I think you mean AP cuts, not distal femur cut. Distal femur cut is already done. If you got your extension gap.
Femur condylar cuts, not distal.
Yeah,
femur
AP cuts, AP cuts, yes.
Posterior,
yes, yeah. Anterior, posterior, and chamfer cuts. While we measured the femur, then there are two pins, one posterior and another is anterior. So after measuring, if we keep the anterior pins and we put the cutting zigs in anterior pins and we downsize or upsize, then can we level it as anterior referencing system?
Dr. Abhijit, can you just mention which system you are talking about? Have
Suppose,
you seen any system where it has got 2 pins anteriorly and posteriorly?
Sir, Depuy and Biored, they all have this posterior to posterior pins, and another after measuring, we can put 2 anterior pins also.
So that means I think he's got a different sizes pins. Don't worry about that, Abhijit.
Yeah,
you can call it as a anti-referencing.
Yeah,
yeah. Next time, show us which company is that. We will see that one and answer you.
Okay, sir. Then I'll make a video and
yeah,
I'll put in the group.
Sure. Who is that?
KS, can you mute, please? Okay, after doing tibia and femur cuts, while trialing is done, we find a small gap between tibial plate and anterior tibial rim in extension. Is it because the slope was wrong? What can be done in such case? If you're finding a selective gap, let's say it's only on the lateral side, it's mostly because of your tight medial space. So it's tight so much that there's a gap anteriorly on the lateral side. But otherwise, without a stem, you shouldn't really get a gap like that.
So it is like a nutcracker effect or booking, na? Anterior lifting, right? What is the question? Read it up.
After doing tibia and femur cuts, while trial is done, if we find a small gap between tibial plate and anterior tibial rim in extension.
Yeah, that's what it is. In extension,
yeah,
that means basically the slope is inappropriate. You must have cut more of the anterior part. Posterior side, the implant is nicely sitting. Anteriorly, there is a gap between the tibial base plate and the bone cut. So that means the slope is not right. It's almost like a reverse slope. The posterior is tight. This will snug fit on the posterior side, and anterior side there will be a gap. It should not happen. Then you should revisit the tibia and cut the tibia properly.
Yeah. Can I go to the video?
Yeah.
Okay. Yeah. Wait, I need to start screen sharing. Visible?
Yeah.
Yeah, I'd like to thank Dr. Reddy, it's his patient, this one, and Dr. Suhas, Dr. Prasha, Dr. Rajiv for curating the video. So let's go over this. So I'm going to play a video. It's actually 16 minutes, but 5 minutes are overlap of the first session. So you just focus on the right knee. We have a 79-year-old patient with a severe varus and FFD. Right side TKR.
meetings
Please.
Mujtaba, please mute.
Yeah.
Mujtaba, please mute.
Yeah. Okay, so I'll just talk over that. The 35-degree varus on the right side, and the range of motion is 30 to 110. And when you go to the, sorry. Yeah. So gross varus with FFD, this is the most common. Now on the X-rays, you see this tibial, the femoral nail in situ. And the information that you get is about the deformity. So you can measure your varus over here, and you can see where the bone loss is. So on the tibia, you can see that the medial, the plateau is kind of thinned out. So you can see the bone loss. You can expect a heavy bone loss in that kind of a case. Then you can see where the osteophytes are. So the location of the osteophytes on the posterior femur, the posterior tibia. So that will help you, of course, yeah, the bone quality was the next one. And as I said, the examination just before starting the case, we gave a valgus stress and it did not correct fully. And then this is your sagittal plane deformity of 30 degree, which is not correcting even after anesthesia. So once you assess this pre-op, we begin with our case. As we discussed, no change in approach. It's a midline approach. So midline incision and the medial parapatellar approach, nothing different in that sense. Only thing is the patella with all these deformities will have big osteophytes. Make sure that cuff is nice. Okay, so you can see here. Yeah, so the medial release, now this is the medial side. The medial release which we discussed has to be all the way back behind the mid-coronal plane. You can see the homens going in and the release continuing all the way till there. And then one more trick to do it is our patella usually is debulked at the end of case, but in these gross varus with FFDs and severe deformities, it's always better to do a level of debulking before itself so that it is possible to move the patella out of the way. And once that's done, your arthrotomy is done and patella is debulked. You can, yeah. Yeah. As we said in the beginning itself, the osteophytes have to be removed. Usually a nibbler is enough to get rid of the osteophytes in routine cases. But in these kind of cases with these massive osteophytes, you can see how the osteotome is being used. Some also use the saw. You can do it as per your preference. It's just faster and more convenient. This rat osteophyte is the one that is under the MCL on the medial side and goes along the posterior condyle. So this is how it has to be removed. Put the osteotome there and then tap off that osteophyte and remove it. Again, this is very important for two reasons. One is it helps in balancing, that is releasing the medial side. And the second is that in soft bones, your cuts can lead to an actual avulsion of the medial epicondyle if that rat osteophyte is not removed in the beginning of the case itself. So that notch is now not visible. You can see there, and how the intercondylar notch is recreated with osteotome. So we tried the Ransol maneuver, but it's unsuccessful because it's so tight posteriorly. It is there's so many osteophytes that you're not able to do it. So it doesn't matter. You can go ahead and do your femur entry. Start with the femur. As we said, extension balancing is most important. Yeah. Drill was hitting the nail. So in this case, we just made a slightly superior entry. Yeah, there. And then went in. There you go. And then take your distal cut. We went ahead with a routine distal cut. We didn't. That's also another thing. Like initially, there's no need to go for excess distal cut. You can just do the routine distal cut, remove the osteophytes, and revisit it at any point of time. If there are any chat questions, Ratnakar, just have a look.
Okay, doctor.
Yeah. You see those pins are still in situ, the distal femur pins. This is one more trick because such deformed cases, you don't know, maybe you have to immediately recut the femur. So just keep those pins in situ, wait for the spacer to go in, and then you can remove it. So as we discussed in the proximal tibia, so we're now doing the extension space. And in that, we finished the distal femur. Now we're going to the proximal tibia. In the proximal tibia, the trick was not to go to the medial defect and size your proximal tibial cut there. Instead, do a lateral based sizing of the proximal tibial cut. Now you can see once we completed the cut and we remove it with the osteotome, look at the size of that cut. Anteriorly, you'll see it as a massive cut because there's an osteophyte over there. It's called the annual osteophyte. So don't get scared by looking at the size of that, but it's look at the lateral plateau, the entire plateau. So you see how little of the medial got cut, right? So we didn't even reach the entire rim, and there's a defect there. Okay, so once that's done, again, the Ransol is attempted, and still we find that there is an inability. There is cannot dislocate the tibia even despite making two cuts. So that's when we have to do something more. That's where the challenges will begin. So you can take a provisional posterior medial cut because it's really that hyperplastic condyle with all those osteophytes at the back that are preventing this movement. So just take a cut, make and create some space over there. Sorry. You can see the osteotome going in posteriorly. It's a curved osteotome. You got an access to the posterior osteophytes by doing that provisional cut, and the curved osteotome will go along the condyles and then remove all those which you saw on the X-ray. You can just, you can't even put the finger, but you know that they're there. So you can just remove them and just create some space over there. So we've gone on to the sizing of the femur. Of course, the spacer part we didn't show here. We showed it in the previous case, but it has to be done, right? So your sizing, again, these two pins being parallel to the tibia, all these were checked. It's not shown in this video. And this is a size 4, and you've made your anterior cut, your chamfers, and your posterior cut. So we're doing a PFC here. So you can see that a size 4 has been taken, and then we're getting rid of all the, finishing up all the cuts. You can just unmute and ask any questions. There's no video noise here, so it's convenient to just go ahead and ask the questions.
How did
Yeah,
you
this
avoid
is
intramedullary nail while doing the distal cut?
No, so fortunately, see, if it would have come in the way to such an extent that we did not, I'll just pause the video, that we were not able to negotiate the intramedullary rod, our jig, then yes, definitely we would have had to do something about it. I mean, we have the luxury of robotic surgery where you don't need to introduce anything, but that will not be there in the conventional cases. So then it becomes really difficult. I wouldn't suggest to make any blind cuts. The idea will be, if it's a healed fracture, to remove the nail and do it. But the other trick is to go parallel to your tibial cut and make a distal femur cut like that. But it's not, I wouldn't recommend to do that in the initial cases at least. Remove the nail, put it in, and put the distal jig and do it.
Two things you can do. One option is just how you have the extension rod. It can remove towards the tibia and even towards the femur also, for us to decide about the level of the cut. So if you have something obstructing the canal, what you can do is you can use an ECG lead, take an X-ray of the hip, and put the ECG lead right on the center of the femur, and then use the cautery, the length of the cautery lead from the center of the head of the femur down to the femoral cut, and you can use that as an external guide for you to decide your distal cut. So it's a little crude way of doing, but at least it will put you in the ballpark as to where you're cutting.
And although I have not seen it, I've heard that there are extramedullary, just like your tibia, there's also for femur some kind of
Yeah, so DePuy has that extension.
Correct.
Where you can put it in and then try to measure it extramedullary.
Yeah. So we were at that level. We finished our chamfer and AP cuts. Now we have more access because the posterior medial cut is completed. So we have more access to that posterior medial osteophytes. We go and get rid of all of them. We saw how the curved osteotome was used to break the osteophyte, and then you can just pull it off with cockers. So once that space is created, we retry the Ransol, but again, we found difficulty in doing that. So we know that this is the location of the osteophyte. So we use a saw and cut off that offending structure. It takes, you need to spend some time in osteophyte removal. It's not easy, but make sure that the entire posterior space is free. That's one of the good tricks to tackle FFD. Again, FFD will be discussed in subsequent classes, so we won't go into the detailing of the release, but for this case, just osteophyte removal is what we are focusing on, right? Alignment is checked, and yeah, this is just an additional cut taken on the tibia because the space was too tight. Just 2 mm more.
In case you remove the nail, do you have to bypass the screw holes by doing a stemmed implant, or no? You can still do just a normal primary cemented.
No, you don't need to. If it's a healed fracture, you can just, because how many will you bypass, right? There's proximal holes, there's distal holes. If you get a short stem and easily the distal holes are bypassed, then fine, but there's no need to do it. So there you go. That's your Ransol being done and the tibia being delivered. So once the tibia is completely dislocated, now the posterior aspect of the tibia is visible. So you know entirely the whole tibia is in view. So now you can do your routine sizing of the tibia, medial osteophyte removal. So size 4 was what was found here to be, and then any excess bone beyond the implant was removed. That's one way of doing the medial osteophyte removal. You can see that saw being directly pointed into that excess bone and removed. Yeah. There you go. Can you see those that attachment there? All the way back posterior-medially, you have the semimembranosus. You see how the cautery is. So that's the answer to the question which was asked previously, where after all that also it's too tight. So these are all the releases. You have to go all the way back, and the osteotome also removing the excess bone from there.
This is one of the rare occasions where we had to work so hard in order to dislocate. But the other thing that you have to understand is unless you remove the osteophytes, you won't have access to the soft tissues, which are tight. So first you get rid of the bone, and right underneath that you will see the semimembranosus.
Shouldn't forget the posterolateral osteophytes as well. The focus is on the medial side, but if there's any evident osteophytes, that'll also make the space tight, no? So you need to get rid of that. This is the routine box cut, nothing different here. Just size 4 boxes being cut, and yeah, I think we spoke twice on the 10 commandments, so we did the same thing here. So I'm just going to fast forward that part. Yeah. Okay. So now you see that bone defect there. Now this is a very important step. See how the bone grafting, we planned a bone graft for this because the defect is uncontained. It is we were not able to manage it with cement and screw because of the depth of that. So you can see it's almost 15 to 17 mm defect. So we needed bone grafting for this tibial defect. Freshen the edges. That's what is being done right now with the saw. Make it flat so that your bone graft can come and sit on it. Now you've already made distal cuts, posterior-medial cuts. So just take a nice cut which will match that particular defect, and then preliminarily fix it with K-wires. Here we've used 2 bone grafts, so 2 small pieces, one posteriorly and one anteriorly. And then you can see the saw right now going on the upper part of that bone graft, just to make it level with the rest of the tibial plateau. And once that's done, you can fix a screw over there. So we went with, as I said, 2 bone grafts, right? So both have to be fixed onto the mother bone. And
is this step cut osteotomy or simple?
So usually the defect is like a saucer.
Okay, sir.
And then the posterior medial cut that you have is flat. So whatever is, it's almost like a U shape, right? So you have to make it flat on flat. So the U-shaped defect, you have to make it flat so that this sits on top. And then before you fix it, you have to drill holes so that you have a good amount of blood coming out through those holes, so that this bone graft integrates.
Yeah, you don't need to make a step cut basically.
Okay, sir. Thank you, sir.
So now you see that question which was asked about the stem extension. For such kind of defects, especially when bone grafts, we mandatorily put in a stem. But for just cement or one screw under the tibia, no, we don't. But when with the bone graft, we definitely put in a stem.
The more oblique the defect, the more chances you need a graft. The more flat it is, you might be able to get away with cement with screws.
I think one small important point here is the lovely bone graft they put there, but just make sure that that's not again protruding out medially. Again, it's going to cause stenting. So just shave off your stuff which is like part of your graft which is protruding out. Here there's nothing protruding out, but sometimes it may. Just shave it off once you put your trial or base plate on top.
Sometimes the graft is much thicker than what you need. So what you can do is you can hold it with 2 cokers on either side, and then you just debulk the graft freehand from a thicker graft to a thinner one. Otherwise, again, you'll start overstuffing both in extension and flexion, and you'll lose your balance. So if you think the graft is too thick and too bulky, you'll have to shave it off.
Yeah. So all this is routine, just like any other case. You put in your femur and then 12.5 insert. So that's one of the tricks of initially, if you saw one of the comments were take minimal cuts. So it's not like a gross deformity. You should go ahead and make cuts because your space will suddenly increase. The space creation has to be more through osteophyte removal and releases rather than bone cuts. So even if it's a gross deformity, ensure that the cuts are minimal. So that's your corrected deformity in your X-ray.
There are two kinds of people.
Right. Richard, can you mute? Yeah. All right. So that's the video that took you through the full course of the case. Any questions there? I can see Ratnakar, you've answered most of them. Yeah.
So one question was how much should be the preliminary posterior medial cut?
How much should it be? So we need to match it to the extension space, no? So
we were unable to sublux the tibia, so we took a preliminary posterior cut femur, right? So how much we should take was the question.
What you can do is you can put your 4-in-1 and through the slot from where you have to do your posteromedial cut, you use the cautery maker mark. Then you know what is your actual cut thickness. Since you haven't decided and you're not going with the actual cut, you can just take 50% of that just to create space for you to go behind. Because if you don't do that, you might over resect and that will be a problem.
Yeah. Does it really matter if we don't keep foot plates of distal femur cutting jig parallel to tibial cut? Is it really matter if we don't keep?
So when we take tibial cut first, then femur cut, then we usually keep this foot plates of femur cutting jig parallel to tibial cut. But if we cut the femur first, then always it's not possible to keep it parallel. So is it really matter?
Are you talking about just the block, distal cutting block?
Not the block. Before we put a zig through the intermedullary rod, then we attach the cutting zig with that block.
Yeah, you can do that also. It should not matter.
Yeah, because the cut is in a different plane, no? So it doesn't have to be parallel. It's just for a convenience of cut. That if it's parallel to that tibial base, that means you can just go straight down and cut. If you make it cross or something, then it's fine. It will still cut the same.
Okay.
Ideally, it is best for you to dislocate the femur, or dislocate the tibia, take your distal femur and balance your extension gap first. If you're unable to do, then you'll have to finish the femur like we did here, where it becomes a little more complex. But 9 out of 10 times, just with the distal cut of the femur and tibia and then removing the osteoids, you should be able to dislocate the tibia. If you want to have good control on your surgery, balance one gap first, which in most measured dissection cases will be the extension gap.
Okay.
So in case of long-standing varus, there is intorsion of tibia. Do we have to take this into consideration for positioning the tibia base plate or proceed with the regular steps?
So we've done CT studies on this, looking at the torsion of the tibia and see whether Akagi line is still a reliable landmark. And we found even in severe deformities, it is still a reliable landmark, because as you have torsion, everything turns. It's not just the tibial tuberosity. As the tibial tuberosity moves, the whole femur moves, the PCL attachment also moves. So as long as you are just on the medial tuberosity and center of the ankle, you are quite reliable in how you're rotating your tibia.
In case of inability to dislocate, we are able to do femoral sizing. Yeah, dislocation is for those posterior osteophytes on the tibia for the tibial size. That's the reason. Without dislocating, you can definitely size the femur. No problem.
So that's where you have to use all three landmarks, right? You have to use white side, TEA, and use the jig, because there is a chance that you might be internal rotating if that is your doubt. Always cross check with all the three bony landmarks.
Yeah. On table, how to identify whether the tibial cut is a varus cut? Simple, your alignment guide will give you, no? Once you finish cutting the tibia, your alignment guide will help you with that.
If the alignment rod is out and the leg is in, it's a varus cut. If the alignment rod is inside and your leg is out, then it's a valgus. If you're confused, the best thing to do is whichever side the rod is pointing towards, cut on that side. Meaning if this is the center, this is medial and this is lateral. If your rod is standing like this, then there is extra bone on this side. So cut that side. That's the easiest way to remember. So if your rod is facing lateral, then it's a varus cut.
If there is a distal femur nail, is it mandatory to remove the nail first? Does it come in the way of the box cut? So we just showed the video, no? Not necessary to remove it. You can just go ahead and start the case. Try to negotiate that, and if the entry of the femoral femur entry is possible, you are able to put your distal femur block with that nail, then no problems. You can go ahead and do it. But if it comes in the way, Dr. Suhas explained one or two more techniques to take the distal cut.
Yeah, and then you can do a CR also. So you don't have to do a PS in such cases.
Yeah.
If you think it's coming too close.
Yeah, that looks good. 9:54. I think if the questions are done, we can wrap the lecture. Any closing comments by Gurava, sir? Right. So Ratnakar, I think next week is valgus, right?
Yes.
Yeah.
Yes.
Okay. So thanks everyone for listening patiently. It's almost 2 hours since we started, and we'll close the session for today. It was good fun to take you all through the varus knee. It's, as sir said, the bread and butter. So really need to know this well, and we'll see you next week for the valgus. Same time, Thursday, 8 p.m. Thank you. Good night.
Thank you. Thank you. Good night.
Thanks, Kushal. Great lecture.
Thank you.
Okay, thank you, sir. Bye, sir.